Hello, this is Dr. John Payne with Piedmont Reproductive Endocrinology Group. I am the third-party reproduction medical director, and I'd like to talk a few minutes on gestational carrier cycles. Gestational carrier in its truest form is someone that carries an embryo that is not biologically created from her own egg, which differs from a traditional surrogate who used her own biological egg, was fertilized with sperm, and then that embryo transferred into her uterus and she carried the pregnancy, which would be biologically half hers. True carrier cycles are really what is done in reproductive endocrinology and infertility clinics these days. Traditional surrogacy, where the woman uses her own egg, really is very rarely, if ever, done in America anymore. The types of patients that could benefit from a gestational carrier would be someone that has the congenital absence of the uterus. In other words, they were born without a uterus, someone that's had a hysterectomy and so no longer has their uterus, someone with recurrent pregnancy losses, and same-sex male couples would need a gestational carrier as well as having to use donor egg plus their sperm to create a child. All these situations are great to use a gestational carrier in, and the evaluation that we do at PREG is complex, but we have many patients who have used gestational carriers, and we have a good system in place to get the evaluations that are needed. First, we like to meet with the intended parents, and of course the intended parents are the ones who are going to use the gestational carrier. It could be a heterosexual couple that is going to use their own egg and sperm. It could be a same-sex couple that would need donor egg along with their sperm, or a single female. It could even be a single male. Really, we can help anyone with the use of a carrier and possibly needing to use donor egg or donor sperm depending on the situation. Once we decide that a gestational carrier is needed, there are many steps in the process to get the gestational carrier cycle done. We have to have a legal contract for the gestational carrier in place, so that requires meeting with a reproductive lawyer who specializes in gestational carriers and adoptions and other things like that, so that the contract that you have is specific for the state that either you live in or that the gestational carrier will deliver the baby in, and these laws vary from state to state, so you really want to have someone who is an expert in that reproductive law to do these contracts for you. We of course would want to evaluate the gestational carrier, and there are standards that we follow for that evaluation, including the typical prenatal panel labs, which include STD labs, checking the labs on their partner if they have one to make sure there are no STDs there, a uterine cavity evaluation of the gestational carrier, including a practice or trial embryo transfer where we pass the catheter through the cervix into the uterus just the same way we want to with the real embryo transfer. And we typically do a saline sonohysterogram or saline ultrasound so that we can evaluate the cavity of the uterus for the carrier and make sure there are no polyps or fibroids or anything that could diminish your chance for success. The carrier's previous OB history and medical history is reviewed to make sure that the carrier seems to be an appropriate candidate and has had typically easy pregnancies, at least one delivery, ideally vaginal, and usually they're younger than 38, but they could be older and generally healthy from a medical perspective. Once we get that evaluation, then we also have to evaluate the intended parents to make sure with a semen analysis that we have sperm to work with, and we do ovarian reserve testing on the woman, which includes a pelvic ultrasound for antral follicle count and labs to look at the anti-Mullerian hormone, endocrine labs, and other STD labs that we have to check in accordance with the FDA regulations for both intended parents. Also, if a woman needed to use an egg donor or a sperm donor was needed, we would help you in that selection process as well. Once the evaluations are done, typically the IVF cycle occurs, stimulation for approximately 2 weeks, an egg retrieval would then happen under IV sedation in our office in either Greenville or Columbia in our OR with our IVF lab. And on that day, the sperm would be mixed with the eggs, usually with ICSI, creating embryos. Those embryos are typically grown to the blastocyst stage on the 5th or 6th day, and that is the point where PGTA, or pre-implantation genetic testing for aneuploidy, could be performed so that you could actually find out which of your embryos are chromosomally normal, male or female, and then we can prepare for a frozen embryo transfer into the gestational carrier. We usually recommend doing PGTA in gestational carrier cycles if possible, for the fact that that will let us most quickly determine which embryos actually should be viable, will allow us to transfer single embryos with a higher chance for conception and at the same time a lower chance for miscarriage, which is important, especially when you're using a gestational carrier, so that you're less likely to have them undergo a miscarriage and need D&C or other treatments which could make them decide that they don't want to do any more transfers. And so if we can get you pregnant, or the carrier pregnant, faster and with fewer frozen transfers, they're more likely to finish the treatment, and financially it's actually advantageous for you as well, because there'll be less treatment cycles and less time that they have to undergo things. So that should actually save money by doing the genetic testing. Once the genetic testing is done, or if not, we prepare to do typically frozen embryo transfers of your embryos into the gestational carriers I had mentioned before. And then after the pregnancy is established with a quantitative pregnancy hormone lab, then we follow the HCGs over approximately a 2-week period, then a vaginal ultrasound at about 4.5 weeks after the embryo transfer to confirm that the pregnancy is located in the uterus, that there is just one, and that we have a heartbeat that's appropriate and size that's appropriate. We'll look several weeks later and then usually release the gestational carrier to her OB doctor, and their care will continue after the end of about the 9th week of the pregnancy. All of the estrogen, progesterone that the gestational carrier used to prepare her uterus and synchronize her uterus with the embryo development will be discontinued, and her pregnancy should really hopefully continue at that point as if she had gotten pregnant naturally, not even using a frozen embryo transfer. I look forward to seeing you at PREG in the future to learn more about this in person and see how we can help you to achieve your goal of starting a family one baby at a time at PREG. Thank you very much and have a nice day.